In the MPN setting, I would say that the strongest message was with regard to, one, understanding that there are new ways of thinking about risk for patients with MPN. There was a lot of data about P53 mutations and that we need to understand that not all of them are bad, but as a double hit mutation is definitely bad. Increasing understanding about genomics, and actually we need geneticists in our tumour boards, to be honest, to help us with the data that we get. There was a lot of very nice real-world data concerning these newer JAK inhibitors and helping us to understand how to use them and who to use them with, and providing reassuring information. So I think that was really important too. Then also quite a bit of data about using cardiovascular predictions. So one of my colleagues, Patrick Harrington, working with other colleagues in the team, presented the data for the use of the QRISK-3 score, which is used by a lot of family physicians in the UK, but patients can actually look it up on the phone and it gives them a rate of risk of vascular complications. This is useful to use in patients with ET and PV. So thinking about vascular risk, as well as just thinking about the controlling the blood counts and the toxicity of the treatment. And then I think it's all about a big look to the future. So the combinations with navtemadlin, the combinations with selinexor, there was a 48-week data as well with Manifest. So that's pelabresib presented. And then quite a few other newer agents, including T regulatory cells, and infusing them for myelofibrosis. But I think what was also notable was what was missing. So what was missing, and we're all waiting for, is what happens when you treat patients with a calreticulin antibody? What happens when you treat patients with a calreticulin BiTE? Alex Rampotas presented his data with a CAR T cell. That's going to be super exciting to see. So, and then we're waiting for the more mutation-specific JAK inhibitors to see how they are and how patients fare with them. So that's all kind of in the pipeline, and we're all waiting for that. So that was missing from ASH, a bit disappointingly, but I guess it's going to make us go to the meetings next year as well.
Well, I think there's a lot going on in MPNs in general. There's a lot of data looking at the influence of mutations, both for risk stratification and prognostication, including TP53, in which there are two abstracts highlighting the adverse prognostic impact of TP53 mutations, both from a survival standpoint, but also leukemic transformation standpoint. And then there's a ton of data emerging on new JAK2 inhibitors, some agents coming from China, as well as non-JAK inhibitor therapies with MDM2 inhibitors, imetelstat, the telomerase inhibitor, and then we're waiting for data to read out, for example, from the independent study with luspatercept, the selinexor Karyopharm phase 3 study of combination selinexor plus ruxolitinib, and there's a lot going on. Still haven't seen data yet on the mutant CALR antibody approach or BiTE antibody approach, and it's still early to look at type 2 JAK2 inhibitor or JAK2 V617F selective inhibitor data. So I think a lot is being presented today, these days, but more to come in future meetings. The other trial I think that is worthy of highlighting is Manifest-2, which continues to be followed up. At this ASH, we're presenting week 48 data, demonstrating durability of spleen response and symptom response, but also these biomarkers of disease modification, whether it's bone marrow fibrosis reduction or driver mutation. And we continue to follow patients both for their overall outcomes and also any imbalances in blast transformation.
So there's of course a lot of trials each year at ASH, and we can certainly discuss those. But I would maybe start by a few of the things that caught my attention regarding things that one can do today or that inform practice today. So, for example, there was a presentation from Europe, Claire Harrison and others in her group, about CALR VAF dynamics. So, as you treat ET patients with ruxolitinib or interferon or anagrelide or hydroxyurea, what happens to the CALR variant allele frequency? And somewhat expectedly, we saw that with ruxolitinib and interferon, it goes down, whereas with anagrelide and hydroxyurea, it goes up. That, of course, is not surprising and actually sort of vindicates what we think. But something provocative that was brought up was that we've known, for example, that anagrelide can cause an increase in bone marrow fibrosis. And what is intriguing is, could that be because it's increasing CALR VAF? We know that CALR is one of the mutations that does increase propensity to developing bone marrow fibrosis. So I found that actually very intriguing. Now, a brief mention of fedratinib, which is a commercially available agent. There were two presentations, one from Andrew Kirkendall of Moffitt from an investigator-sponsored trial in MDS MPN overlap. So it's really nice to see something being done in that space, which really doesn't have a clear standard of care, and clearly fedratinib is an active agent. And then also from the Freedom 2 study, which is post-ruxolitinib myelofibrosis patients, already published in the Lancet Hematology by Claire Harrison and others. But in the oral presentation at this meeting from Dr. Al-Ali, the focus was on low platelet patients, those between 50 and 99,000 baseline platelets, and really goes to show that fedratinib absolutely preserves its efficacy in this group of patients. It might even be better than in patients with 100 and higher platelets. Normally, you assume that the lower platelets are the harder ones to treat, and that is a fact. And but here, somewhat refreshingly and surprisingly, you're seeing as good and perhaps better responses with fedratinib for spleen, for example, in this lower platelet subgroup. Now, this does agree with what we already knew from Jakarta, but the Freedom trials have, the Freedom 2 trial specifically has a much larger sample size. And then I'll just quickly mention that there was a very interesting presentation by Francesca Pellandri from Italy on really looking at maybe if we should rethink, I think we all agree that we should rethink the risk stratification of polycythemia vera. And so they were looking at a number of factors that may inform our decision making and risk stratification beyond the usual age and prior thrombosis, which we have known for a long time. And I'll conclude by saying there was also a very interesting presentation on pulmonary hypertension in myelofibrosis, which we all know happens and can be a difficult problem for our patients. But this particular trial, what caught my attention was that this study that I really noted was that the pulmonary hypertension can actually also correlate with hematologic progression beyond cardiovascular complications, which obviously are going to happen, but also correlated with hematologic progression, just drawing more attention to what is a difficult problem in our patients. There are a lot of trials being updated at this ASH meeting. So just very quickly, there's the Incyte BET inhibitor. There is the Sumitomo PIM kinase inhibitor that I'm certainly watching closely as the data evolve and are updated with more and more patients. Both are very active drugs that could, go on to later phase trials. And then, there are, for example, in systemic mastocytosis, there are bezuclastinib data being updated in both the advanced setting and the non-advanced setting. Naftemadlin has 2 oral presentations this year at ASH. That's the MDM2 inhibitor from Kartos, oral agent being developed in the suboptimal setting, in patients who've been on ruxolitinib. Intriguing presentation from my colleague from MD Anderson, Lucia Masarova, on umbilical cord derived T-cell regulatory T cells in myelofibrosis. So a lot of these agents, are still somewhat early. For example, this one, it's a small presentation on 9 patients, but then you have the others that I mentioned, the BET inhibitor, the PIM kinase inhibitor, naftemadlin. Obviously, a lot of interest around these, and we're going to watch these going forward. Elritercept is a novel activin receptor ligand trap from a company called Keros, which is designed for anemia of both myelofibrosis and MDS. That's being also presented by Claire Harrison. So all of these are drugs to watch, but I would also say, if you look at the agents that are already in phase 3, I think it's helpful to just quickly enumerate those. So imetelstat in the post-JAK inhibitor, sort of JAK inhibitor failure setting, that's the IMPACT MF trial, waiting for the results of that. Luspatercept for anemia in transfusion requiring patients on JAK inhibitors, that's in a fully accrued phase 3, so we await the results of those. We just talked about naftamadlin, that's in the suboptimal setting, getting started with its phase 3 trial. And then there's selinexor, a lot of excitement around that in the frontline setting with ruxolitinib versus ruxolitinib and placebo. So all these different trials are all in phase 3, so all are pretty advanced. But as you can see, in different sort of settings, you have JAK inhibitor failure, you have suboptimal, you have frontline, you have anemia directed. So these are the agents in phase 3 testing right now, and then we already talked about the earlier agents.
I think this year is not that heavy as last year, where we had the 2 phase 3 randomized placebo-controlled studies that unfortunately didn't really show what we expected. So that shaken the field, and this whole year has been marked by defining the endpoints, defining disease modification. How do we get these drugs forward? I think there are great studies. They are still pending. Everybody's looking into the combination of ruxolitinib selinexor, which is having some data this year presented from the earlier studies, but it's enrolling for the phase 3 study in a frontline setting, and we are expecting some top-line data next year or the next year to come in. I think that's a very exciting thing. The MDM2 inhibitor, KRT232, that's also another hot potato or hot topic, where this year at ASH we are seeing data from the Boreos study, which is in refractory setting patients. I think very, very interesting efficacy plus disease modulating data. So a lot of cytokines, inflammation, how do they play a role? What does it mean? Does it really impact the disease behavior long term, and so forth? That pans in with the PIM inhibitor, which currently now has a name as a nuvisertib, which is also being explored in the refractory setting, and alongside the other has a lot of data on the cytokine modulation, correlation with response as well as responses. I think the MDM2 inhibitor is going to spark a lot of attention because there is currently ongoing enrolling a study that has a very unique design that's called Poiesis, where we have it in a frontline setting, ruxolitinib plus or minus MDM2 inhibitor. However, the design is different, where it takes first single agent ruxolitinib, and only after appropriate time, if patients did not achieve suboptimal response measured by standardized spleen and symptoms, they will get randomized to either ruxolitinib placebo or ruxolitinib plus the drug. So here we'll finally learn what does the addition of a second drug adds to non-optimal responders. I'm absolutely so excited about this design because it could provide us a lot of information for our patients for our next design of the studies. And I think that's going to be a hot topic to be presented at ASH. There are fantastic data on interferon across MPNs. There are great data on a lot of prognostication, more and more on molecular. For example, the TP53 role, which has not been looked at that much in MPNs, but now it's spanning across for progressions, and a lot of validation of these different models. I think very, very important for the era of novel therapies. So we're going to probably learn a lot what to do more, how to better design these studies, which will hopefully get us thinking about how do we move on these endpoints and really, really design a drug that's going to get approved and help our patients. Well, 2025, hopefully we'll have some preliminary data on a couple of these drugs, as I mentioned. Interferon, we had basically enrolled the 2 large studies for ET and PV patients with BESREMI. So there's no data yet that have to mature, but hopefully next year or early the following year will bring us the data for PV with the optimal dosing and then ET patients. So that's something that's really there, and that's we all expecting. I'm hoping to see more data on the PIM inhibitor in a refractory setting. I don't know whether we'll be able to see something from the other phase 3 studies, but selinexor, ruxolitinib surely could have something that's going to be there. So those are definitely the front runners. They are there. There are a lot of other newly earlier studies they are currently enrolling and should have updates about where do they play a role in the space. So, and then I finally want to see with the data on the molecular analysis, more importance of these mutations, how they're going to be added on to the currently ongoing studies, whether they're going to define the patients which would need more combos versus single lanes, and then what are the most unmet medical needs where we have to focus our drug development.